Good morning, good afternoon, good evening. This is Dr. Katie Yorediohon. Welcome to Anesthesia and Intensive Care Made Easy. Welcome to classroom. Today we'll be talking about post-operative nausea and vomiting. Don't call it POMF in exam. If you call it POMF, your examiner will be angry with you. Okay? Post-operative nausea and vomiting. It's not a word that you can say POMF. Sometimes we say that, we use that when we are with our colleagues, when we are with our friends, but try not to use that during exams. Post-operative nausea and vomiting. Before you define it and use those terms in it, you must define vomiting and nausea. Vomiting is the forceful expulsion of gastrointestinal content through the mouth. It can actually go through the anus, then to be diarrhea. But when it comes through the mouth, it's vomiting. While nausea is an unpleasant feeling of wanting to vomit. That's nausea. So for the purpose of this lecture, maybe I'll just tell you what regurgitation is. Regurgitation is the passive expulsion of gastrointestinal content into the mouth. You see, it's not forceful, it's passive. And because it's not forceful, it might not come out like vomiting will come out through the mouth with serious force and effort. So it's just regurgitation. It should just come, and then it can't come out. It will come to the mouth. So there will not be a voluntary action trying to pour it out of the mouth, okay? Or you need a suction, high volume suction to suction it out of the mouth, okay? That is nausea and vomiting. So what is post-operative nausea and vomiting? Post-operative nausea and vomiting, you see, you are not putting it in definition because you have already described or you have already defined what nausea is and what vomiting is. So post-operative nausea and vomiting is nausea and vomiting occurring in the immediate perioperative or within 12 to 48 hours after surgery with no cause, rather than the fact that the patient had surgery. No cause, meaning that there's no malaria, there's no gastroenteritis, you don't have any other cause, there's no drug that has induced it. There is no cause, rather than the fact that patient has had surgery. So you will not call it post-operative nausea and vomiting. So talking about, we have risk factor for post-operative nausea and vomiting. The cause, the etiology is usually not clear or it's not known. But there are risk factors that are associated with having post-operative nausea and vomiting. Then we'll talk about epidemiology. Epidemiology, post-operative nausea and vomiting is said to be commoner in female, in younger age group, in children compared to adults. Adults, elderly, old men will not have post-operative, will unlikely have post-operative nausea and vomiting. Then you talk about risk factor. The risk factor, 1, individual that is known to have motion sickness. People who vomit when they are traveling, whether by air, by road. People who are known to have motion sickness are said to have ×4 risk of having post-operative nausea and vomiting. People who had a previous history of post-operative nausea and vomiting in their previous surgery, they are at least ×4 risk of having a repeat or even a worse episode of post-operative nausea and vomiting. There are some clinical conditions that will predispose individuals to post-operative nausea and vomiting. 1, hypotension, dehydration. They will predispose your patient to risk of having post-operative nausea and vomiting. There are some surgeries too that will predispose individual to having post-operative nausea and vomiting. Which surgeries are that? Middle ear surgeries, general surgeries like mastectomy, pelvic surgeries, intestinal surgeries, after intestinal manipulation, pelvic surgeries, they have been seen to be implicated in the occurrence of post-operative nausea and vomiting. You need to look out for more examples, okay, of surgeries that will predispose individuals to having post-operative nausea and vomiting. And there are drugs too that will predispose your patient to post-operative drug use perioperatively, that will predispose your patient to the risk of having post-operative nausea and vomiting. Drugs like opioids, antibiotic use, all right? And the pathophysiology or pathogenesis of this is the fact that the receptors for opioids are seen to be liberal at the vomiting center. And so, in an attempt for opioid to go and act on its receptors, which are very liberal and numerous at the vomiting center, they will provoke vomiting. Antibiotics, you remember that when you talk about the chemoreceptor trigger zone, it actually corrects efferent fibers from the blood and from the CSF and send it to the vomiting center. So when the concentration of antibiotics in the blood is high, the chemoreceptor trigger zone gets that. And it is through this chemoreceptor trigger zone, raised intracranial pressures actually transmit through the chemoreceptor trigger zone to the vomiting center and cause a projectile vomiting. That's just by the way. Okay, so that's how antibiotics and opioids are able to induce vomiting. Other drugs, general anesthesia, all general anesthesia, inhalational agents, intravenous agents, we are risk factors for post-operative nausea and vomiting, apart from propofol, because propofol has antiemetic effect, and so it is not a risk factor for post-operative nausea and vomiting. We talked about clinical condition, we talked about surgical procedure, we talked about types of drug use, all right, and that are risks for post-operative nausea and vomiting. Then we'll now come to management of post-operative nausea and vomiting. You know, in medicine, when you talk about management, you'll be talking about taking history. It has to start from history. So from the history, you'll be able to know that it's a woman, it's coming for general anesthesia, it's coming for pelvic surgeries, it's coming for mastectomy or middle ear surgery, and neurosurgery too is a risk factor for post-operative nausea and vomiting. Or coming for neurosurgery, a female or a younger child, not elderly now. So, or add history of post-operative nausea and vomiting earlier, or add history of motion sickness. So when you look at this from a good history, you'll be able to know the risk factor in that patient. And then examination. If your patient is dehydrated, if there's hypotension, it will put your patient at risk of post-operative nausea and vomiting. So there will be need to adequately hydrate your patient so that your patient can have good mean arterial pressure, a good blood pressure, and then not be at risk of post-operative nausea and vomiting. Early mobilization after surgery is coming. Early mobilization after surgery also puts your patient at risk of post-operative nausea and vomiting. For example, after a surgery, especially a propofol anesthesia, your patient will wake up immediately and be well oriented. And your patient is saying that I want to pee or my bladder is full. And you say, no, madam, let's bring you urine, or God, let's bring you urine and pass a urethral catheter. And he's saying, no, I'm strong, I'm fine, I need to move around, take me to the toilet. Don't allow it, because early mobilization after surgery, too early mobilization after surgery, will put your patient at post-operative nausea, at risk of post-operative nausea and vomiting. So we're talking about examination. You find out your patient is dehydrated, blood pressure is low, then you have to optimize your patient. If patient is paid too, because that can be responsible for low blood pressure, you optimize your patient, adequate blood volume in your patient. And then you now come to investigations. In investigation, the dehydrated patient will have electrolyte imbalance. Okay, urea can be elevated and all the others. You know your patient is dehydrated, and you will hydrate your patient. And then you now talk about management, your plan. What do you have to do? Then we have drug management for post-operative nausea and vomiting. Before you go, before we go to the plan and management, you must know that for every individual that has 2 or more risk of post-operative nausea and vomiting is a candidate for prophylaxis. Otherwise, you will be a bad anesthetist. It is described. Do you know that people who had experience, who had an episode of post-operative nausea and vomiting, describe nausea and vomiting to be worse than surgical pain itself? You know what that means? People who had a patient dissatisfaction, they said that when they had post-operative nausea and vomiting, they describe it to be worse than the surgery, the pain of the surgery itself. So as an anesthetist, you must pay attention to post-operative nausea and vomiting and prevent it. So we talk about the effects, the clinical effects, or the side effects, or the problems of post-operative nausea and vomiting. 1, post-operative nausea and vomiting is a cause of unplanned admission following day case anesthesia or day case surgery, or non-residential surgery, depending on what name you want to give it. Post-operative nausea and vomiting, a patient who came for surgery and was supposed to go home and have vomiting, you see, you cannot send that patient home. So it's one of the causes, or the major cause of unplanned admission following day case surgery. 2, patient dissatisfaction. Patient is sad, is angry, what is this? I would like it. Post-operative nausea and vomiting. 2, electrolyte imbalance. Patient is vomiting, at risk of electrolyte imbalance, even dehydration. 5, the suture, because it can be immediate post-operative. the suture can give way, and that predisposes to hemorrhage. The patient can begin to bleed because the suture or the ligature has slitted because of the force of vomiting. Following the admission to the hospital, they didn't plan it, so it's going to cost money, it's going to cost personnel, it's going to cost hospitals bed space, because they didn't plan to admit such patient. It's going to take space from people who would have benefited, who had elective surgery, who would have benefited for that space. So it's increased cost on the hospital and increased cost on the patient, and it also costs increase in manpower, because patients that was supposed to go home is not in the hospital. You will need extra hands, more nurses to nurse the patient. We've talked about electrolyte imbalance. We talked about bleeding because of slit ligature. So in managing post-operative nausea and vomiting, what are the things you need to do? 1, optimize your patient. I told you dehydration. Ensure your patient is not dehydrated. After taking a good history, the blood volume is adequate, blood pressure is adequate. Then you now come to prophylaxis. There are classes of drugs that are used in managing prophylaxis for post-operative nausea and vomiting. Prevention is better than cure. So what are the drugs? We use gastrokinetic agents like the metoclopramide. Metoclopramide will ensure gastric motility, okay, by decreasing gastric emptying time. Decreasing gastric emptying time and increasing gastric motility. Don't let it deceive you, because it can come in SCQ. They will say metoclopramide. Metoclopramide or placebo will increase gastric emptying time. It's a lie. It decreases gastric emptying time, increases gastric motility in such a way that there is nothing in the stomach, gas is empty. What will the person vomit? Nothing to vomit. That's one pathway. 2, you can use anticholinergic drugs. Anticholinergic drugs like atropine, glycopyrrolate, iosine bromide, all these are anticholinergic drugs. They serve other purposes, but they have antiemetic effect. They can be used as anti-sialogogon, and they can be used as to prevent side effects of drugs like bradycardia and the other things. But in this case, they have antiemetic effect. Then they can use dopaminergic drugs like alloperidol, droperidol. These drugs, they have antiemetic effect. Drugs like 5-hydroxytryptamine class of drug, that is serotonergic drugs like rolacitron, dolacitron, dacitron. They also have antiemetic effect. And steroids have been seen to have antiemetic effect, although the mechanism of action is not clear. It is said that when it is chemotherapy-induced post-operative nausea and vomiting, because it's also a risk factor. For example, you have a patient who has had chemotherapy to reduce the size of the tumor before surgery, and then post-chemotherapy is coming for debulking. That patient has additional risk because the chemotherapy has put the patient at risk of post-operative nausea and vomiting and the other risk that is involved. So for such patients, dexamethasone has been seen to play a very beautiful role in chemotherapy-induced post-operative nausea and vomiting, or nausea and vomiting. And it's also said that combination therapy is the key to post-operative nausea and vomiting management. 1 or 2 or more drugs. And most times, some people will always want Dexa or a steroid to be part of the drug. Another drug whose mechanism of action is still not clear is the drug that is said to act on the neurokinase 1, centrally acting drug. It's a drug that is still being tried in the lab, one of the drugs that are in the future. They act via the neurokinase 1 to prevent post-operative nausea and vomiting. As an anesthetist, you must be seen to be deliberate in the management of post-operative nausea and vomiting, and you must be seen to give prophylaxis for at-risk individual, because its symptoms are described to be worse than surgical pain in itself. The aim of this is to give a beautiful anesthetic outcome and prevent morbidity and dissatisfaction that can be associated with post-operative nausea and vomiting. Hope you have learned something. There's always something to learn at Anesthesia and Intensive Care BSD. There are some people who learn better when they hear people talk about it. It's not like they don't know. It's not like they can't read. They read, but they learn more. They gain more when they hear people talk about it. So always listen. There's something to learn here at Anesthesia and Intensive Care Made Easy with Dr. Katie Yore. Hope you've learned something today. Thank you. Just stay in class. More lectures will come. Bye.